Okay, very good evening, dear students. So, I am Dr. Dharmendra Singh, your psychiatry faculty in PW, MedEd. Basically, as we decided that we are, you know, before exam, we have exam on 5th of November, INICET. For that, we decided that, okay, we'll bring this, previous year MCQs and the important topics we'll try to discuss. So, it can be, beneficial for the students, just quick revision, and it will be beneficial for the exam. So today we are going to discuss the important areas, the important previous year MCQs which has been asked in recent years. And you know that, as always I say in you know various classes, and when I take uh, sessions, that yes, there are in Indian exams, they change the topics, they change the MCQ, but they don't change the topic. So the important area, the hot area remain the same. And this is a, like, even not like 3-4 years pattern, even you last 10 years pattern, you will see, you will find the same thing. So I'll start. I will cover the important topic, as much as possible the important areas, but in between, if you have any query, please let me know. So shall we start? This is very important area, bipolar disorder. One MCQ has been asked: which of the following is false about bipolar disorder? It is most commonly affect the 35 to 45 years. Type 1 is common in both sex. Prevalence in general population is 1 to 2%. Attempt to commit suicide in around 15% of people. So in this, basically, it is the first option. It affects the 30 to 45 years. So we will see whether it's right or wrong. Type 1 is common in both sex. Yes, true. Prevalence is around 1 to 2%. Yeah, usually we say the lifetime prevalence is 1%. Attempt to commit suicide seen in around 15% of people. Correct. So basically, in this answer will be, the option is which is false, not true. So basically, it is affect the around 20 years of age. So 20 to 30 years of age is a age group which is affected by the bipolar disorder. It is not 35 to 45. So this is the answer. Basically, it's not a correct option, so it's a false option. The correct option is it affects around 20 years of age, 20 to 30. We say bipolar. We have bipolar disorder type 1 and type 2. We say around the mean age in type 1 is around 18 years, and the type 2 is around 20 years. Okay, so this is a basically answer will be option A for apple. In bipolar disorder, what they can ask, bipolar disorder, the important area they can ask, just a second, I will add. Okay, the important area they can ask in bipolar disorder, they ask the mood stabilizer, the treatment of bipolar disorder. We use the lithium, we use the sodium valproate, we use oxcarbazepine, we use carbamazepine, and we use lamotrigine. Okay, so in this area they ask the indication of lithium, valproate, this area, so valproate and lithium mainly they target. Lithium, if you open the paper and lithium MCQ is not there, it means the paper is going to cancel, that kind of thing. Lithium always they ask. So lithium, there is a one MCQ, later on we'll discuss about lithium. Sodium valproate, again they ask sodium valproate, the common side effect they can ask, the one of the important side effect like sedation, tremor, the alopecia, thrombocytopenia, increase liver function test or deranged liver function test, and the teratogenic side effect is a neural tube defect. In carbamazepine also, the neural tube, it also causes the teratogenic side effect, neural tube defect. The indication of lithium, if we have a family history of bipolar disorder, then we go for the lithium. And second indication of lithium is no comorbidity. Basically in bipolar disorder, we have a personality and substance use disorder are the common comorbid disorder with bipolar. But if there is no comorbidity, only bipolar, then we go for the lithium. So in this MCQ, answer will be A. Chromosome 18 and 22 are associated with bipolar disorder. That also you have to remember, that chromosome 18 and 22 are associated with bipolar disorder. Chromosome 2 is associated with unipolar depression. Next is the match the following. The kleptomania. Kleptomania, we know what is kleptomania. It is basically the intense desire to steal the item of trivial value. Pyromania, intense desire to burn things. The mutilomania, it is intense desire to mutilate, basically the animals, mutilate the animals. And dipsomania, intense desire to take alcohol, dipsomania. Impulsive drinking, another name of dipsomania is impulsive drinking. So they are the impulse control disorder. In these four are given. Some we say the oniomania, oniomania is impulsive shopping. Oniomania is what? Impulsive shopping. Okay. And we have a trichotillomania. Currently, before we were counting under the impulse control disorder. Now trichotillomania we count under the obsessive compulsive and related disorder. So trichotillomania, we shifted from impulse control disorder to the obsessive compulsive and related disorder. Impulse control disorder, usually sometimes they give the description and then they ask which is a impulse control disorder number 1, and sometimes they can ask the treatment of impulse control disorder. The treatment is habit reversal therapy. Habit reversal therapy is a impulse control disorder treatment. So if you will see, the option 1 is what? Kleptomania. Still 1 will be C, 2 will be D, 2 will be D, and the 3 will be B, and the 4 will be so 1 is what? C, 2 will be D, 3 will be B, and 4 will be A. So in this, answer will be C for Calcutta. Answer will be C for Calcutta. Habit reversal therapy is a treatment of choice in impulse control disorder. A 14-year-old girl presented with sudden onset blindness for the past 4 hours. One option. However, on history taking, it is noted that she is not concerned about it. Although she is presenting with the blindness. Can you imagine the person is having a blindness and he or she is not concerned about it? However, she is concerned that mother passed away recently and she should have spent more time with her. So she is concerned that mother passed recently and I could spend more time with her. Physical examination are normal, so within normal limit. Which of the following is true about this condition? So basically what this condition is talking about, person is presenting with the one neurological symptom, blindness. Person is not concerned. It means what? There is a what we call la belle indifference. La belle indifference that they ask. La belle indifference, basically it's a mismatch between symptom and associated distress. Person is talking about big symptom but associated distress is very less. La belle indifference. La belle indifference seen in dissociative disorder, or we call it a conversion disorder. Dissociative disorder or conversion disorder. Okay. Nowadays even we say functional neurological symptom, and this before we used to call it a hysteria, but nowadays hysteria term we we avoid, because it's a people think that it's a person is doing intentionally, although the mechanism is a dissociative disorder mechanism is unconscious. So it's a the MCQ is about dissociative disorder. Option A is children equally among male and female. No. In adult it is equally among male and female. No. In adult it more common in male than in female. In children it occur more female than in male. So whether it's in children or whether in adult, okay, so whether in children, whether in adult, it is more common in what? Female than male. One thing. So it is more commonly seen in female compared to male. Dissociative disorder. What are the diagnostic criteria of dissociative disorder? Number one, it's an acute, usually acute onset. Person will present with the motor or sensory symptom. Motor symptoms like blindness, aphonia, some kind of paralysis, or functional or pseudo seizure. Sensory symptoms like paresthesia or anesthesia. So first criteria, acute or sudden onset. Second criteria, person present with the motor or sensory symptom. Third criteria is what? Stressor should be present. Without stressor we can't make a diagnosis of dissociative disorder. Stressor, so stressor is given here what? Mother death. Mother passed away recently and she is having that guilt feeling that I could spend more time with her. And the fourth is mechanism is unconscious. So dissociative disorder is not present, person doesn't present intentionally. Okay, so these are the four criteria. We have various types of dissociative disorder: dissociative amnesia, dissociative fugue, dissociative personality or multiple personality disorder, and trance and possession disorder. Among these four disorder, nowadays please remember, in ICD-11 and DSM-5 dissociative fugue has been removed, guys. That also you have to remember. Dissociative fugue have been removed because it's a nowadays rare phenomenon. Very rare these cases we find. So usually dissociative fugue we don't. Dissociative fugue we say it's a kind of amplifier of the dissociative amnesia. Most common dissociative disorder is dissociative amnesia, and further we divide dissociative amnesia. So just remember, most common type of dissociative disorder, dissociative amnesia, and most common type of dissociative amnesia is it's a the circumscribed. Okay, further we divide them further, but don't go into that detail. Labelli indifference seen in dissociative disorder, that they ask what's the treatment of choice? Supportive psychotherapy is a treatment of choice, and SSRI we give for the underlying distress. So this is about dissociative disorder. In this MCQ answer will be D for daily. D for daily. It is whether in adult, whether in children, more common in female compared to male. That you have to remember about the dissociative disorder. Again and again ask, we have a somatoform disorder, we have a dissociative disorder, we have a malingering, we have a factitious disorder. Just remember, dissociative disorder and somatoform disorder is mechanism is unconscious. The malingering and the factitious disorder mechanism is conscious. Dissociative disorder I fully covered. Somatoform disorder briefly. So another name of somatoform disorder is in DSM-5 and ICD-11 is what? It's a somatic symptoms and related disorder, or in ICD-11 we call it a bodily distress disorder. Bodily distress disorder. Okay, in this person will present with the physical symptoms, but investigations will be normal, and actually it's a psychological distress. Person present in a physical way. That's why we call it alexithymia, inability to express emotion. So the common problem we have in somatoform disorder is alexithymia. Person is not able to express his or her emotion. They express their emotion in a physical way. Okay, that's why they present the physical symptoms, but all investigations are normal. Okay, what happens in factitious disorder? Person present these symptoms intentionally. Why intentionally? Because he or she wants to gain the medical attention. They wants to go to the doctor, their physical examination, and it satisfies them. So the intention in factitious disorder is what? Medical, to gain the medical attention, and that's why they go to the multiple doctors. That's why we call them professional patients, because they understand the superficial medical language, because they go to the various doctors, they read about it, they present their symptom intentionally. Okay, they destroy their, they modify their clinical history, they modify their lab investigations, that they modify their the lab investigations. We call it a pseudologia fantastica. Pseudologia fantastica. Okay, and malingering, last malingering, also consciously present. Mechanism is conscious, and what's the intention in malingering? Either to gain the job related gain or financial gain. So the four disorder, again I'm repeating, many students have confusion in this: dissociative disorder and somatoform disorder. Mechanism is what? The unconscious, and the factitious disorder and malingering mechanism is conscious. What is the intention in factitious disorder? To gain the medical attention. What is the intention in the malingering? To gain the financial gain or job related gain. That you have to remember. Okay. Okay. In this MCQ, the patient diagnosed with the schizophrenia started on risperidone. After taking the medication last night, the patient rushed to the OPD today, complaining of upward or rolling of eyes. What is the management of this condition? Okay, so the basically patient having a risperidone. One of the side effect of antipsychotic, we have what? Acute dystonia. Acute dystonia, as the name suggests, it's a acute side effect. Within 2 weeks person is having after starting antipsychotic. Acute dystonia, in acute dystonia person will have a upper body part, basically the neck, the jaw and facial muscles get affected, upper body part get affected. Person is having a ocular muscle involvement, ocular gyrus we say, and the torticollis, sometimes torticollis, the neck muscles. Okay, so the person is having upward rolling of eyes, the ocular muscles get involved. What is the management of this condition? So acute dystonia, it's an acute side effect. It started after within 2 weeks after starting the antipsychotic, and in the treatment of acute dystonia we give what? Intramuscular promethazine. The very common brand name is a Phenargan, injection Phenargan, or in Phenargan we contain the promethazine, or we use the trihexyphenidyl, centrally acting anticholinergic drug. Trihexyphenidyl we use in treatment of acute dystonia. Guys, please remember side effects of antipsychotics, some or other they are going to ask. So the one is the acute dystonia. Second, they ask the akathisia, most common side effect of typical antipsychotic. And akathisia, person is having a subjective complaint of inner restlessness. Akathisia, the treatment of choice is what? Propranolol. But sometimes they can ask the what is the first step you will do in akathisia. What you do, you you decrease the dose of antipsychotic. Despite decreasing the dose of antipsychotic, if person doesn't get the relief, then you go for the propranolol. Drug of choice for akathisia is propranolol. Okay, then we have extrapyramidal side effect, or we say Parkinsonian symptom. What happens in Parkinson disease, students? The Parkinson disease is due to dopamine deficiency. Basically, in Parkinson disease, what we have a tremor, resting tremor, we have rigidity, cogwheel rigidity, and we have a brady or hypokinesia. Same we have in antipsychotic induced Parkinsonian symptom, because by giving antipsychotic, what we do, we decrease the level of dopamine. Basically we create the artificial condition of Parkinson disease. That's why we call them extrapyramidal side effect of Parkinsonian symptoms. Okay, and apart from that, there is a salivation also in antipsychotic induced Parkinsonian symptom. The treatment in Parkinson disease, we give the dopamine agonist, levodopa, carbidopa, etc. But in Parkinsonian symptom induced by the antipsychotic, we give the centrally acting anticholinergic drugs like trihexyphenidyl and benzohexol. Okay, so in this, answer will be promethazine. And apart from that, we have neuroleptic malignant syndrome. The IV dantrolene we use in high grade fever. The CPK-MM will be more than 1000. Okay, and TLC will be high. Parkinson, the neuroleptic malignant syndrome. Apart from that, we have metabolic syndrome. Most common cause of metabolic syndrome by antipsychotic is clozapine. Second most common cause is what? Olanzapine. Second most common antipsychotic causes the metabolic syndrome is olanzapine. The antipsychotic which doesn't cause the metabolic syndrome is what? Aripiprazole and ziprasidone. Okay, apart from that, hyperprolactinemia we caused by the antipsychotic. Because of that person, the patient is the female patient will have menstrual irregularities and infertility, gynecomastia, the galactoria, etc. These are the important side effects of antipsychotics. Okay, so in this answer will be B for Bombay. The next MCQ, which of the following disease is almost exclusively seen in female? That you have to remember, almost exclusively. So it is not almost, but sorry, it is not exclusively, but it is almost seen in females. Yes, it is rare in boys, it is rare in males. It basically, please remember, Rett syndrome is usually we have almost exclusively seen in females. It is rare in boys, but in boys it is more lethal compared to girls. It is more lethal compared to girls. So in this MCQ, the examiner is talking about the Rett syndrome. Okay, in Rett syndrome, what MCQ they can ask? Yes, it is almost exclusively seen in females. It is up to 5 months to 5 up to 5 months. The growth is normal. Growth is normal, and then there is a regression. What happens in regression? There is a microcephaly. Head circumferences get decreased. Okay, and there is a repetitive hand movements. Repetitive hand movements will be there. After 5 months, maximum regression occur between 5 to 48 months. Okay, maximum regression occur between 5 to 48 months. That you have to remember. Okay, just a second. Yeah, okay, that you have to remember. 4 to 8 months. If 2-3 MCQ they can ask about about Rett syndrome. One is they ask the most common cause of death in Rett syndrome. Most common cause of death in Rett syndrome is the respiratory failure. If they ask the most common cause of sudden death in Rett syndrome, then it's a cardiac failure. So you have to see the language of the MCQ. They ask most common cause of death in Rett syndrome, respiratory failure. Most common cause of sudden death in a Rett syndrome, it's a cardiac failure. Rett syndrome is a very important topic. Again and again they ask. Please remember that recently the FDA approved drug, they already asked this MCQ, but they can ask in again various exams. So trofinetide is a recently FDA approved drug for the Rett syndrome that they can ask. So that you have to remember. Up to 2 years we have a Heller syndrome. So in Rett syndrome, up to 5 months the growth is normal, then there is a regression. In Heller syndrome, up to 2 years growth is normal, then there is a regression. Okay, Asperger syndrome, another name of, so we talk about the autistic spectrum disorder. Nowadays we talk about the spectrum. So previously we were calling it a pervasive developmental disorder. Now we call it a autistic spectrum disorder. One of the subtype of autistic spectrum disorder is what? Asperger syndrome. In Asperger syndrome, basically another name of Asperger syndrome is a high functioning autism. Why we call it a high functioning autism? Because there is a no language and cognitive deficit in Asperger syndrome. That's why these children have a better prognosis compared to autism. Okay, corpus callosum is a brain area which involved in a autism. Okay, that you have to remember. Okay, selective mutism, there is it's a childhood anxiety disorder. We have the separation anxiety disorder, childhood separately. One MCQ is given, so there we will talk about it. So in this MCQ, the answer is F for apple. Rett syndrome. Trofinetide, please remember, again they can ask this MCQ. The next one is a patient who is a chronic alcoholic, the present with seizure and altered sensorium. He has been drinking for the past 10 years and take 24 units per day. So since past 10 years he is taking, it means the examiner is trying to hint, give you hint that okay, person is alcohol dependent. Takes the 24 units per day. his last drink was 2 days back. That you have to remember. 2 days back, he is found to have auditory hallucination and secondary delusion. What will you use for the management of this patient? Again and again, this MCQ they ask you. See the last 5-year papers. One of these area, the in alcohol dependence. So we have a simple complicated withdrawal symptom in alcohol, and we have a the simple withdrawal symptom, and we have a complicated withdrawal symptoms in alcohol dependent patients. So simple one are, we have a the tremor, the nausea, vomiting, increased blood pressure, sweating, anxiety symptoms, the sleep disturbance, etc. Most common alcohol withdrawal symptom is what? Tremor. Complicated withdrawal symptom, you have to remember, in complicated withdrawal symptom we have a alcohol withdrawal seizure, alcohol withdrawal delirium, and alcoholic hallucinosis. You have to see the duration. Alcohol withdrawal seizure, usually we have the 12 to 48 hours we are saying. Now these are little the change is there. 12 to 48 hours. Before we were saying the alcohol withdrawal delirium is the between 2 to 5 days, maximum up to 7 days, and alcoholic hallucinosis we say within 24 hours. Okay. Alcohol withdrawal seizure, person will have seizure. The treatment in alcohol withdrawal seizure is what? IV diazepam. Alcohol withdrawal delirium, or we call it a delirium tremens, the usually we say 2 to 5 days, the peak, the maximum up to 7 days. Alcohol withdrawal delirium or delirium tremens, the treatment is what? Long acting benzodiazepines like diazepam and chlordiazepoxide. And alcoholic hallucinosis, the treatment is what? Antipsychotic. Okay, antipsychotics. In this, the patient having a last drink 2 days back and now having auditory hallucinations, secondary delusions. Basically, in this patient, we have a even sometimes they can give you seizure history also. So basically, it's a case of alcohol withdrawal delirium or delirium tremens. In delirium tremens, as I mentioned, the treatment is what? Long acting benzodiazepines like diazepam and chlordiazepoxide. Okay, so in this we will give diazepam. One of the common cause of thiamine deficiency is what? Chronic alcohol intake, and that's why this patient can have a symptom. So along with diazepam, we also give what? Thiamine. Also we will give thiamine in this patient. Okay. Naltrexone is an anti-craving agent. So when we talk about the treatment of alcohol dependence, the first step is what? Detoxification. We do with the long acting benzodiazepines. Then we go for the later on the aversion therapy with the disulfiram and anti-craving agents like acamprosate, baclofen, naltrexone, topiramate, etc. So in this naltrexone we use as an anti-craving agent, but not in this condition when person is in a delirium. Okay. So the answer in this question will be, in this MCQ will be D for daily 1 and 2, the diazepam and thiamine. Flupentixol depot injection we use in a schizophrenia patient, in psychotic patient, where nowadays we have a depot preparation. We give deep intramuscular these injections. The drug get deposited in the muscles, and from the muscles is gradually go into the blood. Okay. So flupentixol depot injection, or the other total 8 antipsychotics we have which come in a depot preparation. That also they ask, the 4 are typical: haloperidol, the flupentixol, the juclopentixol, and fluphenazine. These are the 4 typical, and the atypical are risperidone, the paliperidone, the olanzapine, and the aripiprazole. These are the 4 atypical antipsychotics. They come in a depot preparation. Z-track technique we use for the giving this injection of depot preparation. That simultaneously just I'm telling you. But in this MCQ, it's a case of alcohol withdrawal delirium or delirium tremens, and you give the thiamine and diazepam. Answer will be D for daily 1 and 2. Okay. Next MCQ, match the following. Basically these are the usually in forensic also you read about it, the perversion, that this disorder. We have a eonism. It's a basically the necrophilia, the exhibition, and the frotteurism. Basically the eonism is a sexual, the pleasure by wearing clothes of opposite sex. So one will be C. The exhibition is a sexual, exposure of one's genitalia to the unsuspected strangers. The frotteurism is a sexual gratification by rubbing private part against the another person, and the necrophilia is a basically sexual gratification by intercourse with the dead bodies. Okay, so the one will be you know one will be C, the two will be A, the 3 will be D, and the 4 will be B. That will be the answer. So which will be the answer? The yes, 1 will be C, 2 will be E, 3 will be D, and 4 will be B. So B for Bombay will be the answer. It will be the answer. Okay, so that you have to directly, sometime they ask and you have to directly remember about it. Okay, so important. Previously they were asking more commonly. Nowadays sometimes they are asking, sometimes they are, so directly you have to remember. There is no concept. You have to directly mug up these things. A pregnant mother was on SSRI. The risk of which of the following is increased in the newborn? Okay, so what's the once the pregnant female on a SSRI, what's the chance of increasing? So low 𝐒𝐻𝐃 score. Yes, basically when the mother is on a pregnant female on SSRI, that in newborn the score of the 𝐒𝐻𝐃 score will be the 5 or below sometime. So there is a increased chance of low 𝐒𝐻𝐃 score. True. SSRI increase the chance of ADHD symptom. That is also true. SSRI increase the risk of persistent pulmonary hypertension. Yes, and SSRI also having a chance of delay milestone or developmental milestones. So yes, in this option the all options will be right. All options will be right. 1 2 3 4, 1 2 3 4 will be the right options. So SSRI, it's a most preferred antidepressant. SSRI we have escitalopram, citalopram, sertraline, the paroxetine, fluoxetine, and fluvoxamine. The common side effect of SSRI, we say the nausea is the most common side effect. Apart from the diarrhea, we have diarrhea. The constipation, basically the constipation is caused by paroxetine. Paroxetine causes the constipation. Paroxetine also having an antihistaminic action. So paroxetine is the only SSRI usually we use in the night, because it also gives the good sedation to the patient. Otherwise, if you will use the first time SSRI in the night, they can increase the serotonin level, and serotonin causes the increase the anxiety and causes the sleep disturbance. So you have to be careful. All other SSRI you use in morning, except paroxetine, which we use in the night. Other side effects of SSRI are very important side effect. The sexual dysfunction. In sexual dysfunction, the patient having an erectile dysfunction, and there is a delayed ejaculation. So the delayed ejaculation is a side effect of SSRI, that is we use as a effect in the premature ejaculation patient. Okay, apart from that, there is a vivid dreams. Sometimes they ask the vivid dreams. Vivid dreams is one of the side effect of SSRI. Anxiety symptoms, sometime in night you start, then there is a sleep disturbance, weight gain. Okay, even sometime we say even extrapyramidal side effect also caused by the SSRI. Okay, the weight gain, sometime they cause the hyponatremia. Very important side effect of SSRI, hyponatremia. They ask. Okay, so these are the important side effect of SSRI, most commonly used antidepressant. So they are asked again and again about it. So in this MCQ, the answer will be B for Bombay. B for Bombay. Okay, the most effective drug for smoking cessation. So nicotine, basically when we talk about nicotine, what MCQ they can ask about the nicotine? The substance, this addiction psychiatry is a very important topic in psychiatry. Nicotine basically is the fastest addictive substance. Other substance you have to take for sometime months, years, then you become dependent. Nicotine, if you take 1 month and you are dependent. So it's a, also we call it a gateway drug. Whenever you talk about the talk to the patient about his substance history, initially he started or she started with the nicotine only, the smoking bidi cigarette, the tobacco, chewing the tobacco jarda. That's how they start their substance in their life. uh, the withdrawal symptom of nicotine dependence, they usually ask the decreased attention, concentration, irritability. Please remember bradycardia. Usually we say the all, when we talk about the other substance, the all substance withdrawal symptom, they have a tachycardia, or but the nicotine has a bradycardia. The treatment of nicotine dependence, we have nicotine replacement therapy. Nicotine, we are giving nicotine instead of nicotine. Nicotine replacement therapy we have in the form of gums. We have 2 milligram, 4 milligram gums. It come in the form of patch, 7 milligram, 14 milligram, 21 milligram. It come in a form of lozenges, inhaler. Please remember the nicotine replacement therapy doesn't come in a form of tablet. Okay, we have a varenicline. Varenicline is the important drug we use. It's a 3 months therapy, the 3 months therapy. And varenicline is the alpha for beta 2 partial agonist. The alpha for beta 2 partial agonist, initially we start 0.5 milligram morning and evening for 3 days, then 0.5 milligram and 1 milligram morning and evening, and from 8th day we start the 1 milligram morning and evening. The varenicline, very good therapy. Sometimes they ask the side effect of varenicline. It's a suicide, although it's a people talk a lot about it, but in clinical practice we usually don't see suicide, but from MCQ point of they can ask. So in this MCQ, the most effective drug for smoking cessation is, yes, varenicline. That's true. Although we use nicotine patch, nicotine gum, and bupro, we use bupropion. Bupropion is a what? NDRI, norepinephrine dopamine reuptake inhibitor. Bupropion, 2 3 important thing you have to remember about the bupropion. One, it's a least sexual side effect. That already we have a decreased sexual desire or decreased libido is a important symptom of depression, and when you give the antidepressant, usually they cause that social sexual dysfunction. It's a very distressing for the patient, and that's why the this usually we patients sometimes they don't take the medication or they stop the medication. But bupropion is a very safe antidepressant. It doesn't causes the least sexual dysfunction as a side effect. And bupropion is contraindicated in epilepsy. It can cause seizure, that you have to remember. Okay, and it's a we use as a anti-smoking agent. Okay, so in this MCQ answer will be F for apple, varenicline. Okay, the next MCQ, the true statement about regarding the OCD. The prevalence of OCD in general population is 7 to 10%. No, it is 2 to 3%. 2 to 3%. Atypical antipsychotic are the main pharma treatment in OCD. No, the main treatment is SSRI. Okay, the depression is the common comorbid in the OCD. Yes, it is common comorbidity in the we say the secondary depression seen in OCD. Secondary depression seen in OCD. Okay, contamination is an uncommon obsession. No, contamination is a most common obsession. Okay, so before we were saying that contamination is a most common obsession, and the washers is a most common compulsion, but nowadays we say the checkers is the most common compulsion. So washer, the contamination is the most common obsession, and the checkers is the most common compulsion. OCD, yes, we have due to obsessive compulsive disorder, we have due to dysregulation of serotonin. CSTC loop, the corticostriato-thalamocortical loop is involved in OCD. Another OCD is an important area they target again and again. So CSTC loop, that you have to remember the pandas, the pediatric autoimmune neuropsychiatric disorder associated with beta hemolytic streptococci. These are the beta hemolytic streptococci is an infection. If the child is suffering frequent throat infection with the beta hemolytic streptococci due to autoimmune hypothesis is there, the basal ganglia response due to autoimmune hypothesis, and the later on in adolescent age or the adult age group, that these children are more prone to having a obsessive compulsive disorder, OCD. Pandas, pediatric autoimmune neuropsychiatric disorder associated with beta hemolytic streptococci. Another MCQ they can ask in OCD, they ask the treatment of choice OCD, exposure and response prevention therapy. The drug of choice is fluoxetine. Before we were saying, now we say fluoxamine. The most common or the best modality of treatment is what? Combination of exposure and response prevention therapy plus SSRI, or sometimes they say CBT plus SSRI is the best modality of treatment. Yeah, the exposure and response prevention, what is more important? It's a response prevention is more important compared to exposure. So in this MCQ, answer will be depression is a common comorbidity, okay, in OCD, that they ask. Before OCD we were counting under the anxiety disorder. Now OCD we have a separate category in DSM-5 and ICD-11. And what is that category? That is obsessive compulsive and related disorder. In that, OCD first, second is we have a hoarding disorder, the third we have a body dysmorphic disorder, the fourth we have a olfactory reference syndrome, and the fifth we have a the bodily focused this repetitive disorder like trichotillomania and excoriation. Excoriation is skin picking, and the trichotillomania is hair pulling, picking the hair. Okay, so these are the area they can ask. The prevalence is 2 to 3%. So everything I covered in the OCD, these are the main MCQ they can ask. Then this answer will be C for Calcutta. Okay, this MCQ following the feature of Korsakoff syndrome: anterograde amnesia with recent memory loss, confusion, ophthalmoplegia, and ataxia. Basically, that we have in a Wernicke's encephalopathy. The common mnemonic is what? GOA, global confusion, ophthalmoplegia, and ataxia. Ophthalmoplegia due to 6th nerve palsy, bilateral lateral rectus palsy, and confusion, or we say delirium. Loss of identity, the memory and intact personality, no. Personality get change in the Korsakoff psychosis. Impairment of implicit memory and immediate recall, no. So we have a basically the Korsakoff psychosis. Yes, it's a more severe condition compared to the Wernicke's encephalopathy. It is same due to vitamin B1 thiamine deficiency, and the lesion we have in a mammillary body and dorsomedial nucleus of thalamus. Mammillary body and dorsomedial nucleus of thalamus. There we have a personality changes. In Korsakoff psychosis we have personality changes. There is a amnesia, but many condition we have a retrograde amnesia more than anterograde amnesia. Korsakoff psychosis is the only condition where we have a anterograde amnesia more than retrograde. Okay, so there is a personality changes, anterograde amnesia more than retrograde amnesia. Okay, and there is a confabulation. Confabulation, what is confabulation? Korsakoff syndrome, or we say Korsakoff psychosis. Psychosis means insight is absent. Patient having a memory problems, but patient doesn't have insight that he or she is having memory problems. So patient भूल जाता है, but patient ये भी भूल जाता है कि वो भूल जाता है. So patient having a memory issue, but patient forgets that he forgets, and that's why if you ask any past memory about the past memories to the patient forget that he forgets, and that's why he fill up the memory gaps by false memory. This is confabulation. So filling up memory gaps by the false memory is what? Confabulation. And confabulation is a very unique feature of Korsakoff psychosis or Korsakoff syndrome. Okay, treatment. Please remember, Korsakoff psychosis is not a the fully reverse, not for irreversible condition. It's a reversible, but depend on a severity of the symptom. It is reversible. Sometimes it is half reversible. Sometimes 25%. So depend on a symptom. But please remember that it is not completely irreversible condition. Treatment, yes, we give the vitamins. So initially patient will develop the vernix encephalopathy, and if the patient doesn't come on time or we are not seriously handling the patient, then patient goes into the Korsakoff psychosis. Okay, so it's a not completely irreversible condition. Lesion is same in vernix encephalopathy and Korsakoff psychosis, and that is what? Lesion in mammillary body and dorsomedial nucleus of thalamus. Okay, and this answer will be A for apple. Anterograde amnesia with memory loss. Good. The next is basically the persecution. The persecution we have, it's the paranoid persecution. The onroid state is basically the onrophrenia. Basically the onroid state, the person is having a basically the little the confusion. Okay, so basically it's a like person is having a onroid state is a like dream-like state. Dream-like state. Okay, dream-like state. In this person having a some kind of dream-like state. So it's a basically we have the onrophrenia, that twilight state, twilight like a goduli vela, that during the evening time, neither we have a dark nor we have a sunlight. It's little darkness, little sunlight is there. Twilight state basically the disturbance of the consciousness we say. And the mental subnormality is a oligophrenia. So okay, so one is B, the two is A, the three is the D, and the four is the C. So the answer will be one is B, two is the A, three is D, four is C. So answer will be A in this. That you have to remember. Very important MCQ. Okay, dementia, again they are asking again and again. The most common type of dementia is Alzheimer disease. We have a cortical dementia, we have a subcortical dementia. Cortical is what? Alzheimer disease. We have a pick disease or frontal lobe syndrome. We have a frontotemporal dementia, and we have a Creutzfeldt-Jakob disease. Creutzfeldt-Jakob disease, usually we say the dementia is a gradually progressive disease, but Creutzfeldt-Jakob disease is the fastest progressive dementia because it's a prion disease, is an infectious disease. The prion is a that's why the progression is very faster. The subcortical dementia, we have a Parkinson disease, we have a Huntington's chorea, Wilson disease, HIV dementia, the normal pressure, hydrocephalus, okay, subnuclear palsy, basically all basal ganglia degeneration. And we have a mixed type, cortical as well as subcortical. So we have a vascular dementia, okay, and Lewy body dementia. The most common type of dementia is a Alzheimer disease. Second most common type of dementia is a vascular dementia. Early onset, the chromosome is associated with early onset is what? Chromosome 1, 14, and the 21. Okay, amyloid precursor protein. The presenilin 1 is associated with 14, and presenilin 2 is associated with chromosome 1. And we have a late onset dementia. Chromosome 19 is what? Apoezine, and chromosome 9 is a ubiquitin. So 9 and 19 late onset, and 1, 14, and 21 is early onset dementia. Done. So that you have to remember. Okay, yeah. Next is So this is the uh, apart from that, we have a beta amyloid plaque and we have a neurofibrillary tangle. Beta amyloid plaque is a extracellular finding, and the the neu- neurofibrillary tangle is a intracellular finding. Beta amyloid plaque, neurofibrillary tangle is made up by tau protein. Okay, beta amyloid plaque or senile plaque or neuritic plaque, we call them extracellular finding. Again, and these are the area where they ask all of the following are subcortical except, all of the following are cortical except, some or other thing. Donepezil is the most preferred antidementic drug we use. In this we use MMSE, mini mental status examination. MMSE, the maximum score is 30, 25 or more is no cognitive deficit, 21 to 24 is mild, 10 to 20 is moderate, less than 10 is severe dementia. Okay, there are areas which we address in mini mental status examination is what: orientation, the immediate registration and recall, attention and concentration, and language. Please remember, in MMSE the maximum score we have for orientation 10, then we have a 9 score for the language, we have a immediate registration 3, recall is 3, and attention and concentration is 5. So total we have 3 plus 3 plus 5 plus 9 plus 10 equal to 30. Okay, so this is about the in this answer will be A. The next MCQ, the match the following. The burnout, basically the burnout is the person having getting symptom like exhaustion at workplace to get relieved when not on a duty. So one will be A. Overworked, the exceeding one's ability to the workplace, so it will be D. The suicide is a relationship fallout is a risk factor for suicide, more common with the substance abuse and female the physicians suicide. So 3 will be B. And the 4, the depression, difficult to diagnose because of pride. Yes, sometimes it happens. People think that they are not weak, so they think that how I can have a depression if I'm a very strong person. So they don't understand it's not about strongness or the weakness. So it's difficult to diagnose because of pride. So 1A is A, 2 is D, 3 is sorry, 3 is B, and 4 is C. 4 is C. So 1 is A, 2 is D, 3 will be B, and 4 will be, so 1 is A, 2 is D, 3 will be B, and 4 will be C. So the answer will be D for Delhi. D for Delhi. That you have to directly. So burnout is a getting symptom like exhaustion at a workplace that get relieved when person is not on duty. The overworked is exceeding the one's ability to the workplace. Suicide is difficult to the relationship is a one of the fallout is a risk factor, the more with the substance abuse and female physician, and depression is difficult to diagnose because of pride. So in this answer will be D for Delhi. The next is the risperidone is an off label is not used in which of the following. Risperidone we use in bipolar disorder. Yes, it's antipsychotic, so we use in bipolar disorder. OCD also we use risperidone. We use the 0.5 for 1 milligram. It is really helpful in dementia. That we have roughly 15 to 25% patients of dementia, they have psychotic symptoms like delusions and hallucinations. So although nowadays we have a better option as antipsychotic, but we can use risperidone in the dementia. But of course risperidone we don't use in PTSD. We don't use in PTSD. So answer will be A. So risperidone is a off label, is not used in which of the following. It's a PTSD. Then this answer will be F for apple. Okay, the next, a female patient is having a repetitive thought of contamination with the dirt followed by repetitive hand washing. Which of the following modality will be considered as the therapy of choice? So that already I mentioned that we have a OCD, we discuss in detail OCD, the exposure and response prevention therapy we use in a OCD patient. So that if they ask the treatment of choice, the treatment of choice is the exposure and response prevention therapy. The drug of choice is what? We have fluvoxamine, fluvoxamine, fluvoxamine. Okay, and the best modality is what? ERP plus SSRI, or we say the CBT plus SS, CBT plus SSRI. Okay. Okay, so in this answer will be exposure and response prevention therapy. Exposure and response prevention therapy is the best modality. Okay, dialectical behavior therapy we use in a borderline personality disorder patient. Borderline personality, borderline PD, we use the dialectical behavior therapy. Systemic desensitization is the most commonly used behavior therapy. So we have a systemic desensitization, we have a graded exposure, and we have a flooding. So systemic desensitization is the most commonly used behavior therapy. Okay, there are 4 steps: relaxation exercise, imagination, artificial object, and live object. So 4 steps in a systematically we desensitize the patient from the phobic object. That's why we call it a systemic desensitization. Systemic desensitization. So in this answer will be exposure and response prevention therapy for OCD. Other we have discussed in detail. Okay, the next MCQ, which of the following body focused repetitive disorder is included in obsessive compulsive or related disorder according to ICD-11? Okay, so in this basically we have a as I mentioned that we have obsessive compulsive and related disorder. We have a OCD, obsessive compulsive disorder. We have a hoarding disorder. Okay, hoarding disorder. We have a body dysmorphic disorder. We have a olfactory reference syndrome, it's given, and we have a bodily focused, the repetitive behavior, trichotillomania, and we have excoriation. Okay, excoriation. Okay, excoriation. Okay, hoarding disorder, we have hoarding disorder. Basically it has a worse prognosis in among these disorder. Why it has a worse prognosis? It has a worse prognosis because ERP is not very useful, in hoarding disorder. That's why it has a worse prognosis. ERP is not very useful. Excoriation is a skin picking. Okay, so trichotillomania is hair pulling and excoriation is a skin picking. Olfactory reference syndrome basically we only have in ICD-11, even not in DSM-5. Olfactory reference syndrome, patient thinks that he or she is emitting foul, the foul odor from the body, from the body, olfactory reference syndrome. Hypochondriasis is different. Hypochondriasis, another name in DSM-5 is what? Illness anxiety disorder. Patient is having a preoccupation regarding severe illness. The minor benign symptom or normal physiological functions appear like the serious illness to the patient. This is hypochondriasis. It is nothing to do with the obsessive compulsive and related disorder. So in this answer will be trichotillomania. Answer will be trichotillomania. And another body focused repetitive disorder is what? Excoriation, skin picking. Okay, among these the worst prognosis is hoarding disorder. Okay, so in this the answer will be C. Next MCQ, a 45-year-old man that comes to the outpatient department due to depression. He feels very sad and unmotivated, has poor concentration at work. The patient has no medical history and laboratory evaluation is unremarkable. The major depression is diagnosed and antidepressant medicine is administered. Several weeks later, the patient feel well and depressive symptom, but now distress about the decreased libido and sexual importance. The patient asks for an alternative treatment. Which of the following drug is the most appropriate for this patient? So basically, as I mentioned, the bupropion is the having a least sexual side effect. Then we have a mirtazapine. Okay. Then we have a venlafaxine. Then we have a SSRI, and then we have a TCA. That sequence, guys, you have to remember. But the least is bupropion, so you can say the least is bupropion, and you can say the maximum with the TCA. So either way they can ask you, list is bupropion. If bupropion is not an option, then the mirtazapine is not an option, then you have to go for venlafaxine and then SSRI and TCA. Okay, so in this MCQ, of course the answer will be bupropion. Already I mentioned that you have to go for the bupropion, least sexual side effect. Okay. Okay. The next MCQ, the patient with chronic alcohol use around 1 bottle of whiskey daily, stopped consuming alcohol for 2 days. He was brought to the emergency with symptom of anxiety, uh, hypertension, palpitation. He says that he is seeing snakes and lizards on the floor. There is no history of any seizure. Which of the following should be given to the control the symptom immediately? So patient having a 1 bottle of whiskey daily, so it gives the hint that person is dependent. Now person is stopped consuming alcohol for 2 days. He was brought to the emergency with symptom of anxiety, hypertension, palpitation. Patient seeing the snakes, lizard on the floor, so there is a the visual hallucination. There is no history of any seizure. Basically person is having a what, again it's a case of what, alcohol withdrawal delirium or delirium tremens. Which of the following should be given to the control the symptom immediately? So it's like lorazepam and thiamine. Lorazepam and thiamine. Okay. Lorazepam, usually in the alcohol withdrawal delirium we use the long acting benzodiazepines. Why we use the long acting benzodiazepines? Because it's they control the withdrawal symptom nicely, but long acting benzodiazepines, they are contraindicated in what, liver disease, and the person who is dependent on alcohol, very high chance of alcohol liver disease. That's why if you don't have an investigation facility, or you have an investigation in your hand and there's a LFTR deranged, in that condition you go for the lorazepam. Usually lorazepam we don't prefer because it's a short acting, it's an intermediate acting usually we say, but usually we use the word short acting. The short acting benzodiazepine, but lorazepam is basically not contraindicated in liver disease. So lorazepam and thiamine combination you give in this patient for a safer side, okay. So in this, the diagnosis will be alcohol withdrawal delirium or delirium tremens, and we give the lorazepam and thiamine. Alcoholic hallucinosis, I mentioned that it's the earliest complicated withdrawal symptom which appear earliest. Alcoholic hallucinosis we give the antipsychotic, and we have a alcohol withdrawal seizure which we give the IV diazepam. Okay. A patient with severe depression was treated with ECT. Anesthetic gives succinylcholine and thiopentone to the patient. What did these agents do to the patient? Basically, the succinylcholine is a muscle relaxation. So for muscle relax, it's a muscle relaxation, and thiopentol we give for the general anesthesia. So basically, in this answer will be general anesthesia and muscle relaxation. Combination of succinylcholine and thiopental, or we can say sodium thiopentone or thiopental. ECT, basically remember in 1938 the Sarleti and Binney has given the concept of ECT, and they use the word electroshock therapy. From 1940 in US we started using the ECT. We have a unilateral ECT, only one electrode. We have a bilateral ECT, we use the two electrode. Okay, the initially we were giving the unmodified or direct ECT, but nowadays we give modified ECT. Modified ECT means what? ECT under the cover of anesthesia, and before we were giving the unmodified or direct ECT without cover of anesthesia. The indication of ECT: suicidal patient, catatonia, sometimes the non-tolerable side effect. We give the ECT because patient is not able to tolerate the side effect, and sometimes the treatment resistant various psychiatric disorder, also we use the ECT. Okay, there is no absolute contraindication. Before we were saying the increase ICT is a absolute contraindication for ECT. Currently we say there is no absolute contraindication. All contraindications are what? All contraindications are relative. All contraindications are relative, like increase intracranial tension, like recent myocardial infarction, severe pulmonary disease, retinal detachment. Okay, pheochromocytoma. These are the relative contraindication. ECT, usually we use 8 to 12 ECT. The mechanism of ECT: it increases the brain derived neurotrophic growth factor, so it's a increased level of BDNF. Okay, yeah, the side effect of ECT is what? Memory deficit, retrograde amnesia is more than anterograde, headache, the body ache, the tremor, delirium. It can cause the delirium. Okay, these are the, and prolonged seizure. The seizure is more than 3 minutes, prolonged seizure. Then this answer will be before Bombay. Okay, the next MCQ: a 35-year-old patient come to the psychiatric emergency complaining of being awake for 10 days. He is extremely energetic and doesn't feel tired. The patient is diagnosed with an acute manic episode and hospitalized for further management. The lithium therapy has been started to the patient. When should the nurse to be advised to check serum lithium level? Yeah, as I mentioned, the lithium is a very important drug. Again and again they ask about the lithium. So please remember, number one, lithium, as I mentioned, that it's a indication for lithium is what? Okay, indication of lithium is a number one, no comorbidity and the family history of bipolar disorder. Lithium is having a narrow therapeutic index. That's why whenever we give the lithium, we have to the whenever we give the lithium, because of narrow therapeutic index, we have to check the level of lithium. Usually we check lithium has a any drug, when we check the level, because of once the drug achieve the steady state level, then only there is no fluctuation in a concentration of the drug. Any drug achieve the steady state level only after 4 to 5 half-life. So we any medication, we check the level only after 4 to 5 days. So if they ask that after how many days you will check, if they give the 4th day, 5th day, 6th day, 7th day, your answer will be 5th day. After 5th day you will check the level, and you give the morning and the night. Suppose morning 10 a.m, night 10 p.m, you give the 4 or 5 days, and then you check the level. So you check the after 12 hours of last dose. After 12 hours of last dose in night, you give suppose 10 p.m, then you will check the level around morning 10 a.m. So the 12 hours of last dose. The side effect of lithium are tremor, the ataxia, the memory deficit, the psoriasis, acne. Okay, the diarrhea. These are the common side effect, and the teratogenic side effect is a Epstein anomaly. If the level, usually we say 0.8 to 1.2 is a level millimole per liter or milli equivalent. It's a level should be there in acute phase. In prophylaxis phase we say 0.6 to 0.8. Okay, 0.6 to 0.8. The tremor in the tongue is an initial side effect of, sorry, the first sign of lithium toxicity. The tremor in the tongue is a first clinical sign of lithium toxicity. First clinical sign of lithium toxicity. Done. Then this answer will be B for Bombay. Okay, the next MCQ, the male patient lost his job recently, following which he became irritable and he is sad mood. The thoughts of future made his this mood even worse. He was irritated towards the people in his home, but he occasionally went to for movie with friend, which he enjoyed. After returning back home, again he has a similar symptom. So person is having a symptom, the sad mood, the thoughts of future made his mood even worse. He was irritable towards the people, he occasionally went for a movie with friend, he enjoyed, but again having a same symptom. The person lost the job recently, 1 week back. So basically, when we have a what adjustment disorder. What is adjustment disorder? Basically, it's a, before we are counting adjustment disorder under the mood disorder, now we count adjustment disorder under the trauma and stress related disorder. So in trauma and stress related disorder, we have a post-traumatic stress disorder, we have a acute stress disorder, and we have a adjustment disorder. And adjustment disorder, person is having a one stressor like a immediate, some loss of job, some breakup, some severe illness in the near close people, that kind of stressor. And because of that, symptoms are there, but these symptoms are not so severe that they can fulfill the criteria of depression. And the stressor should be, the symptoms of depressive symptoms should occur within 3 months after having this stress. So say it's say given 1 week, so some serious illness in the close people, some migration, the breakup, the loss of job, these kind of stressors should be there. Number one, depressive symptoms should be there, but these depressive symptoms are not severe enough to fulfill the criteria of depression. And the third thing is the symptom should be within 3 months. Then we call it a adjustment disorder. Sometimes even the stressor is there, but symptom if are so severe that they fulfill the criteria of depression, then you go for the depression rather than adjustment disorder. So adjustment disorder, only three things: one is stressor, second, the depressive symptom are there but not very severe. So even the examiner is mentioned that he went for movie he enjoyed. In depression, patient will not enjoy the movie, so he enjoyed the movie, but after coming back he is having a similar symptom. Okay, so this is adjustment disorder. Answer will be B for Bombay. Okay, next is a 30-year-old woman present the outpatient department with a complaint of difficulty falling asleep for 20 days. She doesn't want to meet her friends when she used to love, spending time. She has a poor appetite and lost 3 kg weight in 2 weeks. Physician started TCA, tricycling, and antidepressant. She reports significant improvement in symptom after 4 weeks. Which of the following is the most important concern of the long-term use of this drug? So basically, TCA is a very, the people were using good drugs initially. What the concern was TCA, what suicide. When the person having a suicidal idea, most of the patient you treat as a OPD patient, not inpatient. You give the medication for 2 weeks. Even you're the best psychiatrist of the world, but you can't predict this. It's very difficult to predict the suicide, and person go home, and very easy patient for the patient to take the medication overdose, and harm himself or herself. So that was a concern of the TCA, that TCA, the overdose of TCA can be lethal. If the patient take the 2 gram TCA, patient can die. That was a very big question mark over the TCA. So basically, in this concern about TCA for the long term use is what? Risk of suicide by TCA. Risk of suicide by the TCA. So not teratogenicity, not the ophthalmic examination for retinal deposit, the regular monitoring of CBC for agranulocytosis. No, it's a basically risk of suicide by TCA, and that's why the later on we started using what? SSRI, not the TCA, because TCA are lethal in overdose. Sodium bicarbonate we use in a TCA toxicity, sodium bicarbonate. Okay, so there is a right axis deviation along QRS, interval, the QT QRS interval, right axis deviation, and the sodium bicarbonate we use in a treatment of TCA toxicity. So in this MCQ, answer will be D for Delhi. The next MCQ, how will you differentiate delirium from dementia in Alzheimer disease? Basically, remember in the Alzheimer disease or the dementia, the person will be, although we say the organic disorder are delirium, dementia, they all come in organic or cognitive disorder, and there is a impairment of consciousness. But please remember, dementia, despite being organic disorder, there is no impairment of consciousness, no impairment of consciousness. So till last time person in dementia is fully conscious, he himself will come to the OPD, he will tell about his symptom, so there is no impairment of consciousness. The cardinal feature, the important feature of delirium is what? Disorientation and impairment of consciousness. Okay, so person having a the disorientation and agitation. Basically in delirium we have the impairment of consciousness, and because of impairment of consciousness there will be disorientation to time, place and person. There will be immediate and recent memory deficit. The remote memory remain intact in the delirium, and there is a sundowning phenomena. In morning and afternoon patient remain better, in evening patient get worse, sundowning phenomenon. Okay, and there is a flocculation, one word we are using, flocculation. Flocculation is what? Basically picking up threads. Picking up threads is a flocculation we use in a dementia patient, in a delirium. The treatment of delirium, treat the etiology. Whatever the cause of delirium, you target the cause. That's a treatment of delirium. We give the low dose of antipsychotic in the delirium, but low dose of antipsychotic to calm down the patient, to decrease psychomotor activity. One of the feature of delirium is what? Increase psychomotor activity. So we give the antipsychotic to decrease the psychomotor activity, but the antipsychotic is not the treatment of delirium. The treatment of delirium is what? Treat the cause or treat the etiology. Okay. Benzodiazepines are contraindicated in delirium except two conditions, like alcohol withdrawal delirium and benzodiazepine withdrawal delirium. These are the two conditions where the drug of choice is only benzodiazepine, long-acting benzodiazepines. Otherwise, the benzodiazepines are basically, they cause the cognitive deficit, so they are contraindicated in delirium. The treatment of delirium is what? Treat the cause, treat the etiology. Okay, okay. So this is a basically disorientation and agitation will be the answer. Okay, the next is basically a 40-year-old patient that came to the psychiatry OPD with complaint of repetitive thoughts, that he feels his hands are always dirty, that they are but though they are not, he knows that these are his own thoughts only that give him discomfort, and he has to wash them. And again, this is a disorder of what? Basically patient the examiner is talking about the obsession and compulsion. So basically obsession and compulsion, they comes under thought possession. So obsession and compulsion, they come under thought, disorder of possession of thought. So disorder of possession of thought or thought possession. So apart from that obsession compulsion, apart from that we have the thought insertion, thought withdrawal, thought broadcasting, also we count under the thought possession. Okay, the formal thought disorder, we have a derailment, tangentiality, the circumstantiality, all these are the form disorder. Flow is, we have what? Like flight of idea is a disorder of flow. So prolixity, flight of idea, these are the disorder of flow. And content, we have a delusion. Delusion comes under content of thought. Okay, with content of thought. Yes, very true. Yes, Achan Khan, very right. True. So delusion is a content of thought is delusion. The form is, we have a circumstantiality, derailment, tangentiality, okay, verbigeration, the word salad we say, these all comes under form. And the flow is flight of idea, prolixity, thought block, they comes under the flow of thought, the disorder of flow of thought. And the possession is obsession, compulsion and thought insertion, withdrawal and broadcasting. This is a little difficult area of mental status examination, but guys, in psychiatry you should know the mental status examination, 1 or 2 MCQ they are asking again and again in this area. Okay. Which of the following antidepressant drug is associated with the least sexual side effect? Already I mentioned the least sexual side effect. We have bupropion, then the mirtazapine, then the venlafaxine. Okay, so then the fluoxetine, then the imipramine. So in this MCQ, bupropion is not given, so the answer will be mirtazapine. Answer will be mirtazapine. Okay, so answer will be mirtazapine. Already in above MCQ we have discussed in detail about it. Which of the following is as these are subcortical dementia? So Parkinson disease, yes. Wilson disease, yes. Huntington's, yes. Pick disease is a cortical dementia. So Alzheimer disease, Pick disease, the frontotemporal dementia, and Creutzfeldt-Jakob disease are the cortical dementia. Parkinson, Wilson, Huntington's, the HIV dementia, the normal pressure hydrocephalus, the supranuclear palsy, they are the subcortical dementia, and vascular dementia and Lewy body dementia are the mixed dementia. So in this will be 1 2 3 will be the answer. Dementia already we discussed in detail. Okay, next MCQ. A 17-year-old male is brought to the psychiatric outpatient department by his mother due to changes in behavior. The mother complains that patient believes someone is sending him signal to save the world for 7 months. It is also associated with visual hallucination and diagnose the thought processes. He is diagnosed as case of schizophrenia. The mother asks about the progress of this disorder. Which of the following factor is not associated with a good prognostic factor? So in a schizophrenia we have a good prognostic factor and we have a bad prognostic factor. Okay, so good and bad prognostic factor. Late age onset, yes, it's a basically, so it is not associated. So late onset is a good prognostic factor. Associated with depression is a good prognostic factor. Positive symptom is a good prognostic factor. No family history of schizophrenia is a good prognostic factor. Female sex is a good prognostic factor. And the poor prognostic factor will be opposite, like early onset will be the bad prognostic or poor prognostic factor. Absence of depression will be the poor prognostic factor. Acute onset will be the good prognostic factor, and insidious onset will be the poor prognostic factor. Okay, so it's a poor prognostic factor. The good prognostic factor will be acute onset. Positive symptom is a good prognostic factor. Negative symptom of schizophrenia is a poor prognostic factor. Okay, so in this answer will be insidious onset. So acute onset is a good prognostic factor. Insidious onset of symptom is a poor prognostic factors. Okay, so answer will be C for Calcutta. In schizophrenia, as the important thing about schizophrenia, the side effect we discussed, the antipsychotic of side effect they ask usually. The depot preparation we discussed, the typical atypical antipsychotic you should remember. The current DSM-5 and ICD-11 changes are there is no subtypes of schizophrenia. Now schizophrenia is schizophrenia. The paranoid schizophrenia, hebephrenic, catatonic, before we were saying, but now the current data studies say that we don't have a data to support these subcategories. So schizophrenia is schizophrenia. The subtypes of schizophrenia have been removed in ICD-11 and DSM-5. That you have to remember. And schizoaffective disorder, like the mood disorder and the schizophrenia together we were calling schizoaffective disorder. So before we were saying that even 2 weeks of depressive symptom and 1 week of manic symptom are sufficient to call it a schizoaffective for depression and mania. But now we say that no, if suppose patient having a like symptoms of schizophrenia for 2 years, you should have almost 2 years symptom for mood disorder, then you can call it a schizoaffective disorder. So schizoaffective disorder now is a longitudinal diagnosis, not the cross section. This is another change in schizophrenia and other psychotic spectrum disorder. Then this MCQ answer will be C for Calcutta. A 36-year-old male present to the emergency department, decreased alertness and mimicking speech for 4 days. The physical examination, the patient initially resists upward movement of arm but later maintains that position. The patient is likely to suffering from a psychiatric disorder. Which of the following is the most effective treatment? So in this the diagnosis will be what? Catatonia. So catatonia, before we were saying that like delirium, we were saying that catatonia is a syndrome which found in a medical illness and in the psychiatric disorder. But in ICD-11 now we have a separate diagnosis of catatonia. Catatonia due to medical the condition or the associated with the mental disorder and the substance induced catatonia. We have a echolalia, echopraxia. We have a various sign and symptoms of catatonia. Okay, so echolalia, echopraxia, we have a negativism, we have a automatic obedience. Okay, we have a Metgehen, Gegenhalten. These are the various sign and symptoms of catatonia. Catatonia, we use what? We use lorazepam. IV lorazepam is a important treatment of, although the etiology or not very clear of catatonia. Some people say there is a GABA involvement, some people say there is a glutamate involvement, but the lorazepam is having amazing effect in a catatonic symptom. If the patient is not responding to the lorazepam, then we go for the ECT. Okay, so in this MCQ answer will be lorazepam. A 10-year-old child presented with a selective mutism, he is most probably suffering from so selective mutism, person is having a failure to speak in a one situation, but he or she speaks in fluently in other situation. This is a selective mutism. Selective mutism we have in a childhood anxiety disorder. So we have a childhood, or we call it a separation anxiety disorder. In separation anxiety disorder, patient having a excessive fear of separation from the attached figure. In this separation anxiety disorder is a like new identity we have in a DSM-5. Before we were not having this diagnosis. In that we have a selective mutism, person having a failure to speak in a one situation, but he or she speaks in a fluently in other situations. So the selective mutism is a childhood anxiety disorder. Answer will be D for daily. Okay, and we have a disorders of attachment, another new identity in the DSM-5, disorders of attachment. So in this answer will be D. Next is basically a 7-year-old child present with the history of bad wetting for the last 1 year at a frequency being twice a week, and through investigation the organic causes have been ruled out. What should be the initial treatment plan? So basically it's about nocturnal enuresis. Nocturnal enuresis with the cutoff age is what? 5 years. The cutoff age is 5 years. Okay, in this, the treatment of choice is what? The bell and pad therapy. Okay, so that you have to remember that the bell and pad therapy is a treatment of choice. The drug of choice is what? Before we were saying the yeah, so before we were saying the imipramine, and we were using, now we say the desmopressin. Before we were using the nasal spray of desmopressin, but the nasal spray causing the nasal bleeding as a side effect. So we use what? The oral desmopressin tablets nowadays. So the bell and pad therapy we use for the treatment of the nocturnal enuresis. We initially rule out the organic cause. So first step, ruling out organicity. Second step is reassurance. If the patient reassurance is not helping for 6 to 12 months, then we go for the treatment. The alarm therapy or the bell and pad therapy is a treatment of choice, and the drug of choice is desmopressin. Okay, that you have to remember. That also very important MCQ. The AIMS people, they love this MCQ, they're asking again and again. Okay, so this is about this previous year's MCQ, dear students. Basically one important point I want to tell you, we have a zuranolone. Okay, so before you have brexanolone we were using in a postpartum depression, but brexanolone we were using as a IV. So zuranolone, it's in latest in August this drug came. It's a like first oral pill came for the postpartum depression, first the oral treatment. So before you had a brexanolone, that you have to remember. again they can ask, that can be, they can ask as a new MCQ. The brexanolone we had for treatment for postpartum depression, but brexanolone we were using as a IV infusion, and the zuranolone is the first FDA approved oral treatment for the postpartum depression. Okay, just in August 2023 this new molecule came. Basically it we are using, it's a basically it's a allosteric modulator for GABA A receptor, the positive allosteric modulator for GABA A receptor, GABA A receptor. So this is the new MCQ they can ask. So almost through these MCQ we touched the all areas, but again I'm saying as a psychiatry faculty said that this is a important area, and the psychiatry, the minor subject, but usually nowadays if you see it, in recent exam usually 8 to 10 11 MCQs they ask from the psychiatry. So understand that the weightage of the minor subject. As I always say, the basic subject and the minor subjects are the backbone of the any Indian entrance exam. Okay, so I hope you will go through these areas and you will enjoy, and it will be very fruitful for your coming exam on 5th of November. Best of luck from my bottom of heart, and just in last few days just go through these MCQs. Only read things what you have read. Don't try to test the new areas, new topics. And now this can harm, not the useful. Okay, and have good sleep, good food, and then the just revise important areas, and I think you will crack. And if not, then it's life is a itself is an exam. So one exam can't decide your future or the whole life. So nothing to worry, just hit properly and then see what happens. Okay, so best of luck. Thank you so much.